The DSM is not the only way to assess patients, and today we speak with Margaret Chisolm about another model, one that developed at the same time as DSM-III and takes the famous manual a few steps further. Welcome to the Carlat Psychiatry Podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a Psychiatric NP and a dedicated reader of every issue.
Psychiatrists used to pride themselves on rich personal histories, the kind that wove together a complex pattern of development, life events, inner conflicts, and outer symptoms. But somewhere along the line, we traded all that for a list of DSM diagnoses. Maybe it was in the 1980s when insurers threatened to withhold coverage if we didn't submit a medicalized list of diagnoses, or the 1990s when industry-sponsored talks started crowding out the rest of the dialogue with their focus on the diagnoses for which their drugs were approved. Or maybe it was when we stopped using psychotherapy as our primary treatment.
But even if you're not practicing psychotherapy, your patients demand a little more. The psychopharmacology revolution has left many empty-handed. Only 1 in 3 recover fully on an antidepressant. Negative symptoms keep people with schizophrenia from leading full lives, even when they respond to an antipsychotic. And 30 to 60% of people with bipolar disorder continue to suffer disabling cognitive problems even after their mood symptoms resolve. Most patients want us to consider all angles of their problem before jumping to medication, and they deserve a full account, and taking one builds trust. Today we're going to introduce you to a method of assessment that does just that. It's called Perspectives in Psychiatry, and it was developed by 2 psychiatrists at Johns Hopkins, Paul McHugh and Phillip Slavney. Other authors have fleshed it out further, like Nasir Gami and Margaret Chisolm, whom we're going to hear from in today's interview.
The Perspectives approach came together in the 1970s and early 1980s, a time when psychiatry was splintered in many directions. There was biological, the behavioral, existential, humanistic, social, cognitive, and the psychoanalytic. DSM tried to reshape these into a single categorical medical model, while McHugh and Slavney, with the Perspectives model, sorted them into 4 different lenses, which we can use to gather a history and find pragmatic solutions for our patients. So you have a way of understanding mental illness at Johns Hopkins that is different from the biopsychosocial model. Tell us about that.
So Paul McHugh and Phillip Slavney, when they came to Hopkins in the mid-70s, were really thinking about what the field of psychiatry needed to move the field forward. And they developed this model called the Perspectives of Psychiatry, which really just makes explicit what psychiatrists are doing implicitly. And it really provides a framework, a way of understanding how to think about the origins of patients' problems. And it's not so much focused on diagnosis, but more on formulation of patients. So understanding the origin of the problems, prioritizing the treatments, and then helping people live their fullest life possible.
Mm-hmm. And what are the 4 perspectives in that model?
Sure. So the 4 perspectives, there's a mnemonic called HIDE. Is this something a person has, the disease perspective? Is this problem emerging from who the person is, the dimensional perspective? It's about personality. Is this problem or set of problems the patient is bringing, is this emerging from something the patient is doing, like restricting their food intake or using substances? So that's the behavioral perspective. And then the 4th perspective asks the question, is this problem emerging from something the patient has encountered? And that's the life story perspective. So HIDE, H-I-D-E, is it something the patient has a disease? Is it coming from who the person is, dimensional? Is it because of something the patient is doing, behavioral? Or is it because of something the patient has encountered? And that is the life story perspective. So Those are the 4 perspectives.
So a problem that a patient presents with could fit under all or some of these perspectives?
Yes, that's a really important point. These perspectives interact with one another. So obviously how someone reacts to something that they encounter is influenced by their personality, by the dimensional perspective. If somebody has a disease, that's a life event that they've encountered, and they're going to need to make meaning of that naturally. And so that's an interaction between the disease and the life story perspective. So yes, they all interact with one another. When we teach the perspectives, we separate them out, but in actual practice of the perspectives, you need to integrate that with every patient.
Now, the DSM, I believe, views all 300-something disorders through one of those perspectives, the medical model. Is that right?
Well, I don't think that was what it was intended. I think the DSM was intended to be atheoretical and not really talk about the origins of these syndromes, but by classifying them or categorizing them in the way that they are with these checklists of signs and symptoms, there's an implication that these are diseases. And so that's, I think, really limited our ability to care for patients in a holistic way, because we frequently go to the disease perspective, see if somebody meets the signs and symptoms within that checklist. And if they do, we stop there. Now, we also use the DSM at Hopkins. We can use that with the perspectives model, but we just don't stop at giving somebody a DSM diagnosis. We say, okay, is there another perspective from which we could look at this patient's problems? Maybe it's not all disease, or maybe none of it's disease, or maybe it's all disease. But regardless, disease is happening in a person who has a certain personality. This disease is happening in a human being who naturally is going to make meaning of what they've encountered. And so it's always important to look at a patient from all 4 perspectives, even if, the primary problem that's bringing them in is best explained as a disease, a clinical syndrome that runs a course together that has some underlying pathophysiology and ultimately an etiology.
That makes sense, because I've never understood the physiology of adjustment disorder. So on that note, are there conditions or diseases in the DSM that you think are better suited to the other lenses? I mean, clearly, maybe schizophrenia is well understood through the medical model, but are there other perspectives that are better suited for some of the conditions in the DSM?
So there are some conditions in the DSM that are clearly not meant to be diseases, like adjustment disorder, for instance. So that's one point I just like to make, even though most of them we think of as diseases. Not all of them are. Certainly in the older versions of the DSM, the personality disorders weren't thought of as necessarily diseases. But I would say that there's 2 distinctions. One is that, as I said, we're not really looking at diagnosing people as much as formulating and understanding the origin of their problem. That's always at work, even when we're thinking about somebody as having a disease. And clearly there's some diseases in the DSM, schizophrenia, traumatic brain injury. Those kinds of things are pretty well agreed upon, clear manic episodes, pretty agreed upon that these are diseases. But there's a lot of gray area, depressions and a huge gray area. And now we have the prolonged grief disorder diagnosis. I would say there are conditions or problems that are better explained as having emerged from something that somebody has encountered, or their personality, or something that someone is doing. I know a lot of psychiatrists look at addiction as a disease. We actually make a distinction, and we're not saying that there aren't biological bases, but we're saying that there's something qualitatively different from schizophrenia that comes upon someone, and opioid use disorder that, if somebody's on a desert island, they're not going to express. I am addiction medicine certified. I'm not going to win any popularity contest necessarily among the addiction community when I say this, but I think people know this, that experience addiction, that there is an element of choice involved. And AA recognizes that there's an element of choice involved. Now that choice gets very, very diminished over time as people are conditioned and their drive increases. It makes it much harder to make a different choice. It's not a trivial choice at all to use drugs, but there is an element of choice that is different from schizophrenia or mania. And we look at this family of behavioral disorders, substance use disorders or eating disorders, for instance, and we look at what they have in common. They do have a conceptual triad that unites them of choice, conditioned learning, and drive.
Okay, so you mentioned those are perhaps better understood in the behavioral lens.
We'll say that I think this problem is best understood from the behavior perspective, but that doesn't mean it's not a medical perspective. We're just saying it's not a disease in the same way that schizophrenia or mania is. And rather than searching for the pathophysiologic process and the etiology, perhaps it would be better to, and offering a cure in that sense, maybe it would be better to intervene in diminishing drive with medication, which we can do, or offering a way of conditioning away from that behavior, or helping support people in their choice. So it's not that we don't see it as medical, and we certainly recognize the biological forces and might even offer medications, but those medications aren't sort of targeted to a broken part necessarily, but to interrupt the behavior by interrupting some part of that cycle.
For clarity, is drive synonymous with cravings?
No, I mean, it could be, yes. I mean,
I'm used to
I think of
drive is a good thing. You want them to have drive. But
well, yeah, but it depends on what the object of the drive is. If it's pedophilia, you don't want them to have drive, right? You want to lower the sex drive.
Let's pause for a preview of the CME quiz for this episode. Earn CME for each episode through the link in the show notes. 1. Which of these is not among the 4 perspectives in psychiatry as described by Dr. Chisolm? A. Disease perspective. B. Dimensional perspective. C. Cognitive perspective. And D. Behavioral perspective.
So I'm imagining this like 4 levers, and as you listen to the client and understand them, the different levers may be going up or down. Like if they made a suicide attempt during a manic episode, the disease model is going to be high. Otherwise, suicide attempts might be understood as behaviors with a life story that culminated in a series of events.
Right. I mean, it is, the perspectives is used because it is this visual metaphor looking at people or looking at their problems from these different perspectives. And when somebody is telling me their history, I am kind of always in the back of my mind thinking, okay, this is making it seem more like a disease. This is sounding more like a behavior. They're interacting in this way. So yeah, they're not mutually exclusive. They're interacting, and different perspectives may be more relevant at different stages of an illness. I use the term illness broadly, by the way. It doesn't just mean disease.
I understand. Maybe this is no coincidence that this developed at Johns Hopkins, where Adolf Meyer taught, and I believe a strong element of his perspective was atheoretical, but looking at the multiple ways that life and environment and biology intersect and interact with each other.
Yeah, so Adolf Meyer, was very interested in understanding the patient's life course, and we have some of the drawings that he did of people's life histories. There are these torpedo drawings. There are these very detailed histories. So that's our biggest legacy from Adolf Meyer at Hopkins, is we take a very, very detailed, thorough history, starting with the family history and then moving forward in time to the presenting problem. It usually takes me at least an hour to go through the history with the patient. And then sometimes it's taken much longer, but usually just an hour. But it's very complete. And at the end of the hour, I usually have a pretty good sense of who the patient is as a person, what they've been doing, and what they've encountered in their life, so that I can put the present problem in that context of who they are.
Adolf Meyer was the first chair of psychiatry at Johns Hopkins and is one of the most influential psychiatrists of the 20th century. He believed that no single theory held the truth for a patient and instead took a pragmatic approach, mapping all the biological, social, and psychological influence in a timeline of the patient's history. He viewed mental illness as a reaction to these influences, and you can see his influence in the early editions of the DSM, where every disorder is classified as a reaction.
It sounds like you take a psych history somewhat historically, looking at how these different perspectives play out at different years of life. Is that accurate?
Well, what I'm trying to do in taking that history is really get a sense of who this person is, what they've experienced, what their risk factors might be for diseases, obviously with the family history and things like that. The main goal is to understand them as a person and to understand the nature of the problems that they're bringing to us, so that then we can figure out how best to treat those problems.
And it sounds like indeed you use this model with every patient. Is that right?
Absolutely. Sometimes I'm very explicit about the model and say at the beginning of the session, when somebody comes with these problems, this is how I think about things. Is this something you have? Is this because of who you are? Is this because of something you're doing? Is this because of something you've encountered? How do you explain what's going on? Or how do you understand what's going on? And often they'll say, oh, it's all of the above. So sometimes we're very explicit. Not with every patient do I do that, but, often it's helpful at the beginning to hear what the patient's perspective is on their problems.
And it sounds like regardless of the problem they bring to you, this approach might empower them to be more of a partner in change.
Definitely. It's a collaborative process. After the hour of questions, I always ask, well, first of all, I give a role induction before the hour of questions. I'll ask them if they've ever been to a psychiatrist before. And then I'll say, this may be different from what you've experienced before, because I'm going to ask you a bunch of questions. It's going to take about an hour. And then after that, I will tell you, what my thoughts are, and we can go from there. And so at the end of the hour of questions, I usually ask, is there anything I didn't ask or you didn't tell me that you think is important for me to know? Usually they're so exhausted by that time, they say, no, you know everything about me. But then I will say, what I think. I'll share my formulation using the perspectives. I'll say, I think this is a clinical syndrome that you have. There's some risk factors you have for that, if I think they have a disease. But I'll never stop there. I'll also say what I think, is their affective temperament and how that might be playing a role. I will talk about, if they are doing something maladaptive way, role of that in their problems. And then I'll talk about the relevance of the life story to their problems. Obviously, if somebody's coming with grief after a death, could be hugely important. And I'll say, this is how I'm understanding things. What do you think about that? And then I'll get their feedback on that. And then I'll say, okay, so we agree that this is a disease. Here's some possible ways that it can be treated, and have a discussion. I'll do that with all the perspectives if it's relevant.
Margaret Chisolm is a professor of psychiatry at Johns Hopkins University. She has authored over 150 scientific papers and 2 books that explore the perspectives of psychiatry, one for professionals, Systematic Psychiatric Evaluation, and one for patients, From Survive to Thrive, Living Your Best Life with Mental Illness. A shortened version of this interview appeared in the March 2022 edition of the Carlat Report and is available online.
Send us your feedback to asktheeditor@thecarlatreport.com. And a special thanks to Daniel Zigman of McGill University, who sent us a correction on last week's episode. When listing medications with strong anticholinergic effects, we mentioned hydroxyzine, also known as Vistaril. We were wrong. Hydroxyzine is only weakly anticholinergic. This mistake is an important one, and it points to a psychopharm paradox. Both hydroxyzine and diphenhydramine are antihistamines. But in the US, hydroxyzine is prescription only, while diphenhydramine is available over the counter as Benadryl. So the paradox here is that the prescription version, hydroxyzine, is arguably safer than its over-the-counter cousin, diphenhydramine. Diphenhydramine is strongly anticholinergic, while hydroxyzine is only weakly anticholinergic. Here's how you can use this in practice. When you see a patient taking over-the-counter diphenhydramine for sleep, or any over-the-counter sleep aid, they usually have them in there, offer to trade it out for the safer prescription hydroxyzine, if that approach is appropriate. Also, a lot of patients take this diphenhydramine for sleep in the form of a pain med combo like Tylenol PM or Advil PM, even when they don't have any pain. It's terrible marketing. And this is another opportunity for education. Tell your patient that the extra pain medicine is not helping them sleep at all and may be harming their liver, stomach, or kidneys. Better to skip the Tylenol or ibuprofen and take diphenhydramine by itself. Or better yet, switch to hydroxyzine.
Next week, we'll talk with Dr. Chisolm about the questions she uses to get at the 4 perspectives in psychiatry. Read the full articles and earn CME credits at thecarlatreport.com, where we have a special offer for our podcast listeners. You can get $30 off your first year subscription with the promo code PODCAST.
Thanks for watching. Hit subscribe if you enjoyed this content. And to earn CMEs for listening, head on over to thecarlatreport.com/podcast.